Good morning. I can't believe today is the last day of February. Can you? Am I the only one amazed at how quickly 2018 is flying by? As I woke up this morning, I thought, wow, February 2018. How can time fly so quickly? So I turned to my husband and I said, it's 2018. And yet I still feel like I'm 30 years old. To which my husband said, well, you don't look 30. Now, I'm guessing his good ear was down on the pillow, and he didn't understand what I said. But regardless, with age comes forgetfulness, so I'm sure by our 24th wedding anniversary in May, I will have forgotten this morning's comment, probably by the time I get home tonight. Welcome. I am so pleased to be able to welcome you this morning. I'm Cammie Hart-Anderson. I'm a manager with Snohomish County's Human Services Division of Behavioral Health and Veterans Services, and I am so pleased to be able to welcome each of you this morning. Also, with age and life experience comes a desire to give back, to make the world a better place. Each of you, and I'm just so impressed at how many people are joining us today and tomorrow. Each of you, teachers, social workers, tribal members, paraeducators, social service professionals, community collaborators, community members, and parents are here today because you want to improve the lives of children and adolescents, our young people who have been affected by trauma and adverse life experiences. And so I want to thank you for dedicating the time to join us and to move our efforts forward. Working together, we can shift the paradigm as we work to build a safe, compassionate, resilient communities throughout our county. Now with that, working together, so much has already been accomplished. The Snohomish County Children's Wellness Coalition has over 50 partners and really has been the impetus for the trauma-informed work. How many of you are members of our Children's Wellness Coalition? Look at all the hands. That's really impressive. And I know you're currently working on our third annual Youth and Family Wellness Fair that's scheduled for Saturday, May 5th. And if you're not familiar with our wellness fair, there's a flyer in your packet. We've also got 17 schools within 7 school districts in the process of becoming trauma-informed. And we so appreciate our partnership with Continued Consulting in helping make this happen. 45 agencies are being trained next month to become trauma-informed designated sites. Snohomish County Human Services is partnering with ESD 189 to provide signs of suicide training for all our school districts. We have student support advocates in 8 school districts currently. Dual certified clinicians are providing co-occurring services in 3 school districts. Steps towards adopting trauma-informed practices within our juvenile justice system are underway. Strengthening family programming is being rolled out. Human Services is joining forces with Live Healthy 2020 and Child Strive to work towards a trauma-informed and restorative community. And this conference, today and tomorrow, is just another step forward. We are fortunate to have many dedicated community partners that have made this conference possible through their generous contributions. OSPI, ESD 189, North Sound Behavioral Health Organization, CASA, which is the Court-Appointed Special Attorney or Advocates. All 5 of our managed care organizations that are dedicated to serving those with Medicaid coverage also contributed. That includes AmeriGroup, Community Health Plan of Washington, Coordinated Care, Molina, and United Healthcare. And also, last but not least, is our Snohomish County Human Services Department, which I'm a part of. Speaking of human services, our division, the Behavioral Health and Veterans Services Division, will be releasing $450,000 of local mental health and chemical dependency tax funds to expand prevention programming in our county in coming months. So each of you here today will soon be receiving an email announcing that application process. So you are the first to hear that exciting news. Thank you. All right. I've been asked also to share a couple of housekeeping items. The restrooms are out the door and to the left, close to the stairs and the elevator. Clock hour forms and evaluations are at the registration table in the hallway. As questions come up, we've got 6 people here who could answer any question you have. Amanda Frankie, John Walters, Cleo Harris, Laura Moat, Sheila Blunt, and Liza Patchen-Short. They are all members of my behavioral health team, very valued, and without them, this conference wouldn't have come together today. So with that, will the 6 of you please stand so folks will know who you are? So any question at all, they are your source. Now, I want to make sure each of you received a bag. You found it at your table there. Everybody got a bag? Okay. The bag contains resources, the program. Yes, lunch will be served at 12:30, and some surprises that were paid for by our sponsors. So how many of you are old enough to remember the Oprah show? A few of you? That's good. Do you remember how she'd give away gifts, surprises? All right. Well, everybody in our studio audience today is receiving not 1, but 2 books to help you advance this movement. Trauma Stewardship by Laura Van Dernoot Lipsky and The Deepest Well by Dr. Nadine Burke Harris. Yes. Oprah sent a great example, didn't she? And with that, it is my pleasure to introduce to you Dr. Nadine Burke Harris. Dr. Burke Harris was born not too far from us in Vancouver, BC. She earned her master's degree in public health from Harvard and her medical degree from the University of California, Davis. Dr. Burke is the founder and CEO of the Center of Youth Wellness located in San Francisco. Dr. Burke Harris is a recognized pediatrician known for linking adverse childhood experiences and toxic stress with harmful effects to health later on in life. She is an advisory council member for Hillary Rodham Clinton's Foundation's Too Small to Fail campaign. Dr. Burke Harris is truly a pioneer in the treatment of toxic stress. And with that, please join me in welcoming Dr. Nadine Burke Harris.
I am so happy to be here. It's such a pleasure and an honor to be able to start off this day, start off this conference with you all. And if I can remember my computer password, we will get going. This, I was mentioning earlier this morning that it's really exciting for me to be here. I got a lot of invitations to speak, but the work that you all have been doing here in this county has been on my radar for quite a bit of time. And the opportunity to come and share with you all and learn a little bit from you, but really to kind of stimulate and galvanize the movement, for me was something I simply couldn't pass up. And so I want to start by just doing a quick, I know that a lot of folks are really familiar with the Adverse Childhood Experiences Study. How many folks feel like you're really comfortable with the information from the Adverse Childhood Experiences Study? Okay, that's amazing, a lot. And so I'll jump in and talk a little bit about that, but I really want to focus on solutions and what our next steps are. So for me, I'll start by saying that this work for me began over a decade ago when I finished my residency in pediatrics at Stanford, and I started a clinic in one of San Francisco's poorest and most underserved neighborhoods called Bayview Hunters Point. And as I was in this community, and I I did a funny thing. I did what folks do when you really want to be effective in underserved communities. I spent some FaceTime. And, I went to schools and to churches and to after-school programs and community programs. And I said, send us your kids. We're opening this clinic. Send us your kids. And an amazing thing happened. People actually sent us their kids, right? And most often it was with, a plea or an entreaty. Folks would say, please, Dr. Burke, this was before I was married, they say, please, can you see Bobby? Bobby's fallen out in class. He can't sit still. He's hitting the kid next to him. Please, Dr. Burke, he's got ADHD. Can you put him on some Ritalin? Right? But when I did what I was trained to do, right? When I did a thorough history and physical exam, what I found was that for most of the kids that I was seeing, I couldn't make a diagnosis of ADHD or attention deficit hyperactivity disorder. And the reason for that is when you look at the diagnostic criteria, right? Because I'm really kind of a stickler. I'm super hardcore about, criteria and all that stuff. It's just like the science nerd in me. It showed all the symptoms that my patients were having. Inattentiveness, impulsiveness, difficulty with being able to focus and attend, right? But at the bottom, there was one line. And that one line said, and these symptoms are not caused by any other mental health disorder, right? Now, I'm not a mental health professional, right? But the thing that popped into my mind was, what if it's, not necessarily a mental health disorder per se? What if it's a biological process that is causing these symptoms, right? Because if this kid was having these same symptoms because of, a brain tumor or some kind of organic disease, I couldn't call it ADHD. And what I noticed was that there was this really concerning pattern, which was the patients who seemed to have the worst symptoms also coincided with the patients who happened to have the histories of significant doses of adversity. Kids who were witnessing domestic violence, or who had a parent who was mentally ill or substance dependent, or kids who had experienced abuse or neglect. And the weird thing was, it wasn't just their behavioral symptoms, right? So when I'll never forget, I had one patient, and her 10-year-old girl, her mom brought her in, and she had really difficult asthma, right? And I spent all this time going through, what are her asthma triggers, and we went through, there was no pet dander, there was, she's not allergic to pollen. We went through the, dust covers on the pillows and the mattresses, all this stuff. And as I sat down with her mom and said, can you think of anything, like what could it be that could be activating her asthma symptoms? I remember this mom said to me, Doctora, I noticed that my daughter's asthma tends to act up every time her dad punches a hole in the wall. And so for me, observing that trend, that my patients with the highest doses of adversity were the ones that were having the greatest rates of not only behavioral, but health problems, for me, that got me diving into the science. It got me looking to try to understand, how is it that what kids are exposed to, right? The adversity that they're exposed to affects their developing brains and bodies. And then one day, my colleague walked into my office, and he had a piece of paper in his hand, and in his hand was the Adverse Childhood Experiences Study. And for anybody who's seen my TED Talk, that day not only changed my medical practice, it changed my career. So the Adverse Childhood Experiences study was done by the CDC, the Centers for Disease Control and Prevention, and Kaiser Permanente. And in it, they asked 17,500 adults about their histories of 10 categories of what they called adverse childhood experiences. And these include physical, emotional, and sexual abuse, physical and emotional neglect, or growing up in a household where a parent was mentally ill, substance dependent, where they're incarcerated, where there was parental separation or divorce, or domestic violence. And for every yes, you'd get a point on your ACE score. And what they found was absolutely striking. The first thing that they found was that adverse childhood experiences, or ACEs, were incredibly common, right? 2/3 of the population had at least one adverse childhood experience, right? So, and 1 in 8 individuals had 4 or more adverse childhood experiences. So in the United States right now, according to the National Child Health Survey, there are almost 35 million children who have experienced adverse childhood experiences. Right now, today. And when we're looking across the U.S., this is not, right? This is not something that only happens in certain places, right? Every state in the nation is affected. And, you know, when I did this, when I found this research, right? You know, I was working in a community that was a very low-income community, predominantly black and brown community. But what we found is that when we look across race and ethnicity, right, that adverse childhood experiences affect, you know, every racial ethnic group, every income group. In fact, the original ACE study was done in a population that was 70% Caucasian, 70% college educated. They all had great health care as members of Kaiser, right? Here we see the California data on racial and ethnic background on the 10 traditional adverse childhood experiences. And what we see is that they're surprisingly similar across the 10 traditional ACEs, across Caucasians, African Americans, Hispanic or Latino in California had the highest rate of ACEs, of both 1 or more and 4 or more. And what we know from that, right, is that we know that the 10 traditional ACEs that were developed by Kaiser and the CDC are not the only adversities that children experience, right? This doesn't include discrimination. It doesn't include, you know, separation from your parent or caregiver by deportation or migration. It doesn't include other things that could also be really stressful or traumatic. But when it comes to the traditional 10 ACEs, right, this is everybody, right? This is everybody. We're all at risk. So the second thing that they found as part of the ACE study was that there was a dose-response relationship between adverse childhood experiences and health outcomes. So here's a list of the 10 leading causes of death in the United States of America. And having an ACE score of 4 or more dramatically, I'm not talking about a little bit, I'm talking about dramatically increases your risk for 7 out of 10 of the leading causes of death in the United States, right? I'm talking about double the risk for heart disease, double the risk for cancer, triple the risk for chronic respiratory disease, 2.5 times the risk for stroke, 11 times the risk of Alzheimer's, 1.5 times the risk of diabetes, 30 times the risk of suicide, right? So we're not messing around with a little bit of increased risk. We're talking about seriously increased risk for the conditions that, by the way, are the leading causes of death in the U.S., right? We're not talking about some random obscure disease that nobody ever known about or heard about, right? This is having a major impact on the health of our society. And for those folks who are deeply familiar with the ACEs data, you might notice that a few of these numbers are different from the traditional ACE data. And the reason is because some of these numbers are pulled from the global ACE data that was published in 2017 by Hughes and colleagues. So this is the most updated data, not from the Kaiser CDC information, but also including the latest data from Hughes et al. That looked at ACE's impact across more than 20 countries around the world. So I'm hoping that I've convinced y'all, right, that number one, ACEs are incredibly common. Number two, their impact on health is substantial. And in fact, without intervention, individuals with 7 or more adverse childhood experiences face a 20-year difference in life expectancy, right? So if this doesn't qualify for a public health crisis, I don't know what does, right? So, all right, so when I learned this information, the first thing that came to my mind is, what the heck do I do about it, right? Because I'm a pediatrician, I'm a scientist, and when we have this information, right, the first thing is, okay, so how do we use this information to improve the health of kids and adults? So the first thing for me is really understanding the mechanism, right? Because when we understand the mechanism, when we understand not only like what biological processes are happening, but how, then we can use that science for intervention and treatment. And let me just give you a quick example of this, y'all. So back in the day, back in the 80s, early 80s, when I was, just a young thing, doctors were seeing patient after patient coming into the ER with these weird, high rates of diseases that we already knew about, right? So people were coming in, high rates of tuberculosis, right? And we said, oh, tuberculosis, I know that, and I know how to treat it. Here, let me look up the treatment. Here you go. Here's your prescription for the treatment of tuberculosis. And then folks were coming in with this high rates of these rare pneumonias called pneumocystis pneumonia. We're like, pneumocystis pneumonia, it's rare, I gotta look it up, but I know how to treat that. Here you go, here's your prescription. And then people are coming in for these even more rare, kind of odd skin cancers, right, called Kaposi sarcoma. And we're like, oh boy, that's a tough one, but I know I got a colleague I can refer you to, right, like we know how to treat this, here you go. And what happened? Patients kept on coming back. And they kept on, and they were sicker and sicker and sicker. Because even though we were doing what we were supposed to do to treat the pneumonia and the tuberculosis and the Kaposi sarcoma, patients kept on coming back because we weren't treating the underlying cause. And the underlying cause in that situation was a virus that was compromising the very immune system, HIV. Right? And once we understood that, then we were free to, mess around and figure out how to solve this thing, right? So we were like, oh, man, it's a virus. Okay, let's target that. Oh, wait, no, it's not just a virus, it's a retrovirus. Okay, we're going to develop antiretrovirals. And what happened? The mean mortality for HIV/AIDS went from 6 months, right? In 1983, the mean mortality, 50% of people were dead 6 months from diagnosis, to today, when the life expectancy is greater than 50 years from diagnosis, right? We did that in 30 years, y'all, right? And we did it from knowing the mechanism, not just treating the surface symptoms, but treating the underlying problem. And that is why it was so critical for me when I was seeing patient after patient coming in with what looked like ADHD to get to the underlying cause so that we can be more effective in our treatments. So when we look at our biological mechanisms, when we get into the nitty-gritty, because for me this is the fun part, how does this work, right? Ultimately, it all comes down to our body's fight or flight response. And it works a little something like this. Imagine you're walking in a forest and you see this guy, right? What happens? What happens in our brains and bodies? Immediately, our amygdala sounds the alarm, right? Because bears are scary. And it activates our bodies to release stress hormones like adrenaline and cortisol. And so our hearts start to pound, our pupils dilate, our airways open up to take in more oxygen, and we shunt that oxygen to our big muscle groups, right, for running and jumping, right, and away from that itty-bitty muscle that holds your bladder closed so you might pee your pants, right? But now you're ready. You are ready to either fight that bear or run from the bear. But if you were to think about it, fighting a bear would probably seem like a terrible idea, right? Look at him. He's got teeth. He's got claws. And that is why your amygdala alarm actually sends brain cells, neurons, to the prefrontal cortex, the part of our brain responsible for executive functioning and judgment, right? And it turns it way, way down. It inhibits the prefrontal cortex because you don't want judgment getting in the way of survival, right? And instead what it does is it turns up a part of the brain called the noradrenergic nucleus of the locus ceruleus, or as I like to call it, the part of the brain responsible for, I don't know karate, but I do know crazy, right? It's the within the brain stress response center, and it's responsible for getting us amped up. Now, one slightly less obvious thing that happens when we activate our fight or flight response is that it also activates our immune response, right? Because if that bear gets his claws into you, you want your immune system to be primed, to bring inflammation, to stabilize that wound so that you can live long enough to either beat that bear or get away. It's brilliant. It's elegant. It was evolved over millennia to save our lives from a mortal threat, right? But the problem is what happens when that bear comes home every night. And this system is activated over and over and over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health-damaging. And it actually loses its ability to turn itself off normally. And what happens as a result is that we see long-term changes to children's developing brains and bodies. We see changes to the regulation of the fight or flight response that leads to overactivity and difficulty turning off the stress response. We see overactivity of the amygdala, which means that folks have increased fear around stimuli that maybe shouldn't necessarily be that fearful. We see inhibition of the prefrontal cortex that leads to challenges with executive functioning. We see toxicity in the hippocampus, which leads to difficulty with learning and memory. And we also see, and this is something that doesn't get a lot of airtime, changes to a part of the brain called the ventral tegmental area. This is the reward center of the brain. It runs on a dopamine circuit. It's activated by all the things that make us feel so good, right? Cocaine, heroin, sex, high sugar, high fat foods. And what we know is that when folks are exposed to high doses of adversity, especially in childhood, it affects the structure and function of the way that the reward center of the brain works, putting people at increased risk of engaging in high-risk activities. And this, for me, was critically important because when the ACE study first came out, folks thought, oh, those people, right? You know, sure, they've got a history of childhood adversity, but they just the reason they've got health problems is because they drink and smoke and do all this high-risk behavior. It's not a health problem, it's a behavior problem, right? But it turns out that there is a neurobiological reason that puts people at increased risk of engaging in high-risk activities. And that's really important to know. So now, I don't know, as you all are looking at all these biological changes, that sounds a heck of a lot like the patients that folks were sending to me, doesn't it? Right? Sounds a heck of a lot like that kid who couldn't sit down and pay attention and control his impulses in class. But in addition to the changes to the neurologic system, right? Because I think when we talk about early adversity and we talk about adverse childhood experiences, a lot of folks are beginning to intuitively understand that it's associated with changes in brain structure and function, because that's the thing that gets the most airtime. But I want to tell folks, don't forget about the rest of the body, right? Early adversity is associated with long-term changes to the immune system that leads to increased risk of chronic inflammation, and also changes to the way that the immune system works that puts kids at increased risk of things like viral infections, certain bacterial infections, right? We also see changes to hormones, right? Long-term changes to our stress hormones leads to increased stress activation in the body. And we also see changes to all kinds of other hormones, growth hormone, thyroid hormone, pubertal hormones, that can lead to changes in growth, development, metabolism, and puberty. We see changes to some of the hormones that are associated with weight control, right? These obscure hormones called leptin and ghrelin that lead to increased risk of overweight and obesity. And the effects of early adversity on our health goes all the way down to our DNA. What we see is that early adversity, high doses of adversity in childhood, are associated with changes in the way our DNA is read and expressed, which leads to changes in the way our brain and our organ systems respond to stress, right? Because a lot of folks thought, hey, I get it that someone was exposed to adversity in childhood. That makes a lot of sense. But, why would they have increased risk for heart disease? They've gone and left the house by now. You'd think that they could pull it together, right? But it turns out that these changes in the way that early adversity affects our DNA is in part changes the way our bodies function over the long term. And we also see increased risk of something called telomere erosion. Telomeres are the bumpers on the ends of our DNA. They protect our DNA from wear and tear. And the faster your telomeres get worn down, the faster it leads to early cell death, right? And we see, early adversity is associated with increased wear and tear on our cells. And all of these long-term changes are what is now called by the American Academy of Pediatrics, right? Toxic stress, right? These are this is the way in which early adversity leads to long-term changes to the brain, the immune system, the hormonal systems, our DNA regulation, and this is what leads to these long-term health problems. And one of the things that's important is that this new science, this emerging science, is also telling us things like, protective factors make a difference and can actually help to prevent this process. But also, some kids are more vulnerable for various reasons. So there's predisposed vulnerability. And so one of the things that was really important for me when I first started this work was understanding, okay, I get it. The ACE study was really powerful and important, but I'm a pediatrician. I'm seeing kids, right? So long before my kids get heart disease or stroke or something like that, what does this mean in terms of what I should be looking at in front of me every day? And our team at the Center for Youth Wellness, and one of the biggest things that I did when I learned this information was to figure out how do we put the pieces together to create solutions, right? So I'm just going to say right now, like how many folks, after hearing all the science, after hearing the deep biology, how many folks are feeling a little depressed, right? How many folks are like, oh my God, right? So I'm going to tell you, when I learned the mechanism, when I learn this deep dive science, like, oh my God, it changes us all the way down to our DNA, it actually, for me, was the opposite effect. For a minute, there was a little bit of gloom and doom, and then I was just like, oh, wait a minute. So now that we know this, now we actually have way better tools to begin disrupting this. And I'm going to get to the hopeful part in a minute. So one of the first things that I did was to create my center, to start the Center for Youth Wellness. And our mission is to prevent, screen, and heal the impacts of adverse childhood experiences and toxic stress. And one of the first things that we did was to look at all the research and figure out, what does this look like in kids, right? What does this look like? So it's great that we know these long-term impacts, but what does this look like so that we can recognize it in the kids in front of us? And what we found is that the effects of toxic stress are evident in childhood. As early as infancy, we can see things like developmental delay, growth delay, failure to thrive, and sleep disruption. In little kids, we see increased risk of asthma, pneumonia, viral infection, atopic disease like eczema, learning difficulties, behavioral problems. And then as kids get older, we see increased risk for things like obesity, diabetes, headache, abdominal pain, teen pregnancy, hyperthyroidism or autoimmune disease, and pubertal changes, right? So now, when we pull that information together, that means as a doctor, I can begin sharing with my colleagues like what we got to look out for, right? Because we know these kids who present with behavioral problems, right? I'll tell you, oftentimes I feel like they may be the lucky ones. They frankly may be the lucky ones because if they present with behavioral problems, at least it gets recognized. We in our minds make the association between early adversity and a kid who is acting out in class or elsewhere. But for the child who doesn't have behavioral problems, they might have asthma, they might have growth delay, they might even have autoimmune disease. But there are too few of us who are recognizing, oh my goodness, this could be a manifestation of childhood adversity. So knowing how we are better able to recognize the signs helps us to be able to identify the kids who are at high risk. So once we have this information, what's the prescription? How do we use this? Now this is the fun part. So one of the first things that we did at our center was we actually did something called a chart review. We looked and said, hey, how many of our kids is this affecting? Like, sure, those white folks at Kaiser may have had adverse childhood experiences, but who knows if my kid's in Bayview Hunters Point? Nah, I'm just messing around, but I'm a researcher. I got to document stuff, right? So we went through and actually did a chart review of 702 charts, and we actually calculated, based on what was documented in these patients' records, how many adverse childhood experiences that we had evidence for. And what we found was that very similar to Filiti and Anda, about 2/3 of our patients had at least one adverse childhood experience, and 12% of our patients had 4 or more adverse childhood experiences. And there was 2 things that were striking in our data. Number one, our kids who had 4 or more adverse childhood experiences were twice as likely to be overweight or obese, and were 32.6 times as likely to have learning or behavior problems as our kids who had 0 adverse childhood experiences, right? And when the statistician from Stanford sent us the data, I almost missed it. Because for our kids, I almost missed the really exciting part. I was so busy looking at the odds ratio and the relative risk and all that kind of stuff that I almost missed that for our vulnerable Black and brown, low-income kids in Bayview Hunters Point, if they had 0 ACEs, only 3% of them had learning and behavior problems. These are all kids living in the same neighborhood, all kids who are, coming to the same clinic, But if they didn't have any ACEs, only 3% of them had learning and behavior problems. Versus if our kids had 4 or more ACEs, more than half of them had learning and behavior problems. And that told me something really important, because right now, the #1 treatment nationally in the United States for ADHD is stimulants, right? But this data was telling me that actually, if I have a kid who's coming in to see me and I think they've got ADHD, if I don't do an ACE score, right? If I don't understand what their ACEs are, I may not be giving them the right treatment. Because this is a graph of the function of the prefrontal cortex, the function of our executive functioning in response to what we call catecholamines, which is essentially adrenaline, right? And the way that it works is, if you got too little, your function is terrible, right? So you start on what would be your left side of the curve. And so for that kid, adding stimulants makes a lot of sense, right? You add stimulants and you see this kid go up, 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 up the curve. Awesome. That makes, that's what treatment is for. But the problem is, if a child is equally low on the curve, but they're way over on what is to your right side of the curve, because they have high doses of adversity and they actually have overactivity of their stress response, then what is adding stimulants going to do? It's actually not going to help, right? And this is why understanding the science really helps us to do more efficient and more effective care. For the kid who is on this side of the curve, reducing the dose of adversity and enhancing the ability of the folks in their environment to be buffering caregivers is actually going to be one of the most important components of the intervention. So for us at the Center for Youth Wellness, one of the most important things that we learned from the research is that early detection makes a huge difference, right? I'm going to say this again. Early detection allows us to do early intervention, and early intervention is one of the most powerful tools we have. And so what we did at the Center for Youth Wellness is we created this very simple screening tool where we listed the 10 traditional adverse childhood experiences. And we also listed some supplemental criteria, things like foster care or harassment or bullying, having a parent or guardian who died, right, which wasn't in the original ACE study, or discrimination, separation from your caregiver by immigration or deportation. And what we asked folks to do was not tell us which specific ones that their kid had experienced, only how many. And the reason we said only how many is because, I think I had been screening for ACEs for about 7 years by the time that we fully kind of brought this together, finalized this screening tool. And in order to be able to, this is difficult stuff. Let's get real. This is not, these are challenging issues. And in order to be able to make sure that every single one of the 12 patients that are on my calendar for the afternoon gets a screening, it's going to be impossible for me as a primary care provider to unpack the individual ACE items for every single child, right? And oftentimes, in my experience, it's actually better for families to get into the details of which specific ACEs that their child has experienced with someone who has the time, the training, and the capacity to be able to go through, right, whether it was physical or emotional or sexual abuse or neglect or parental substance dependence. So the way we do it is, my job as a primary caregiver, my job is to screen. And once I have that screening done and I understand whether my patient is at low risk, moderate risk, or high risk for toxic stress, then I simply refer them on to my colleagues who then do this multidisciplinary care, right? And that multidisciplinary care includes, mental health, social work, case management, home visits, right? All of these different things. And we do this in a model that is beginning to be a best practice model, which is integrated primary care and behavioral health. So that's how we do it at our center, right? Yay! And let me show you how this works. So I had an almost 3-year-old girl who came into my clinic for her regular physical. She had moved from another state. She came in to see me because actually her little brother had been sick, seen in the ER, in the emergency department. They said, make sure you follow up with a primary care doctor. So she came in for a regular visit. And at her visit, her mom said, I got no worries, no complaints for my daughter. The only thing is she's a little small, right? And when I graphed her on the growth chart, her mom wasn't messing around. This girl was itty bitty. In fact, she was below the 3rd percentile for height, for weight, and for her head size. And so when I requested her records from her previous doctor, what I saw was that over time, she was born, 50th percentile for height, 50th percentile for weight, 25th percentile for height. But over time, she had dropped off the curve and had gone below the 3rd percentile for all of her parameters. So for me as a doctor, that meant that she met the criteria for a condition called failure to thrive. And when I did all of the typical, I sent labs, I did, an x-ray of her left wrist to look at her skeletal maturity, I did all the stuff. I did developmental screenings. But the one thing that gave me an indication of what was going on with this child was I did the ACE screening that you see in front of you. What do you think her score was? 7 on the traditional ACEs, and then 0 on the supplemental ACEs. This almost 3-year-old girl had an ACE score of 7 out of 10, right? And what that meant for me was I was able to say to her mom, because of what your daughter has experienced, I believe that her body is actually making more stress hormones than the average person. And I think this may actually be the issue that's associated with her growth. So I'm going to refer you to someone who can help you understand how you can help to reduce your daughter's dose of adversity and also enhance your capacity to be a buffer. Because guess what, Mom? Biologically, you have the capacity to be a buffer to your daughter's stress response. But in order to do that, your own stress response has to be in good working order, right? So in order to do that, you got to put your own oxygen mask on first. So I referred her to something that's called child-parent psychotherapy, which is a 2-generation intervention that worked with both mom and child to reduce the dose of adversity and enhance the buffering capacity of this child's environment, right? And this was her original growth chart. I don't know if y'all can see it, but you can see her height and weight were both dropping off and ended up below the 3rd percentile. And once we did this child-parent psychotherapy intervention, this was her growth chart, right? Within 6 months, this girl was back on the growth curve. This is what this looks like to do an ACEs-informed practice in primary care. But the thing that's amazing is that it's not just in primary care that we can be doing this work. There are excellent organizations around the country who are doing this now in education. And the National Child Traumatic Stress Network has actually created a toolkit for child trauma and how to approach it for educators. There are incredible organizations like Turnaround for Children, right, who recognized that, especially in very high-need communities, we're not talking about 1 kid or 2 kids, right, who may be exposed to high doses of adversity and may be experiencing a toxic stress physiology, right? We're talking about sometimes half, 2/3, or maybe even most of the class, right? And what that means is that even though there may be 10 or 15% of kids that qualify, that really need, specific one-on-one therapy, we need to understand this underlying biology in our approach to creating trauma-informed and trauma-sensitive learning environments, right? So let me tell you something. I was talking to an educator recently who was saying, oh my goodness, this is so challenging. As an educator, how am I supposed to respond to this, right? And one of the things that I said to her was, we all take for granted that educators are supposed to be able to deal with behavior problems in kids. But if you had a classroom of 30 kids and 20 of them had epilepsy, you wouldn't ask that educator to just deal with that. We would recognize that that was a health condition. This is why this paradigm shift is so important. Understanding that for an educator who's teaching a classroom full of folks, full of kids, right? And 15 or 20 of them may be dealing with a toxic stress physiology, you're asking an educational professional to deal with a health problem. And that's not fair, right? Once we recognize that that is the fundamental issue, then we need to bring greater resources to help our educational colleagues be more effective in what they're trying to do, right? And a couple of the things that we can do is helping to support with mental health and social work supports in schools, to do universal training so that everyone in the educational environment, from the bus driver to the teacher to the principal to the lunch lady, knows how to recognize symptoms of toxic stress in an educational environment, right? And rethinking school discipline to go from reactive and punitive to working with a student's biology instead of against it. And so what Turnaround for Children did was they really worked on creating this framework that really recognizes that the foundational components for learning, right, include attachment, stress management, and self-regulation. And without that, it becomes much more challenging to have an environment where children are able to have a rich and robust educational environment. Another organization that's doing amazing work in the educational space is the Center for Wellness and Achievement in Education in San Francisco. And they have implemented an intervention called Quiet Time. And Quiet Time is essentially it's like meditation in schools, right? So one of the things that's actually been shown to be an extremely effective intervention is mindfulness-based practices and meditation. And so they implemented this quiet time intervention where kids were trained where they can either, do the meditation practice, or they can do some other quiet activity, quiet reading, or something like that, right? And they did this in junior high schools and high schools in San Francisco. And what do you think happened? They saw a reduction in school violence in John O'Connell High School. They saw a substantial drop in the suspension rate. They saw an increase in GPA after implementation of this program in both the high school and the middle school. They saw a reduction in the achievement gap, and I want to focus on this lower graph here. They saw a reduction in the achievement gap across the board, but the greatest gains in the achievement gap were in the kids who had the lowest GPA. So those who were worst off actually did the best. And specifically, they saw an even greater reduction in the African American achievement gap, right? Which was incredibly powerful. But not only did they see, these improvements, they also saw, which I guess is important to educators, increase STAR test scores, right? Like these standardized testing scores. And what I think is perhaps, equally as important as the gains that they saw for students, they also saw improved outcomes for administrators and teachers, with reduced depression, reduced anxiety, and reduced anger, right? Which was incredibly powerful. So, and in this situation, the educators actually also participated in this mindfulness quiet time training. So, for me, this understanding of how early adversity affects our biology, right? And how it changes the way that our brains and bodies function is as fundamental as germ theory, right? It's like learning that, oh my goodness, infections are actually, back in the day, right? Scientists and doctors, we thought that infections were caused by foul airs, right? And so we did things to target the underlying cause, which we thought was these foul airs. So we did stuff like opening the windows in the operating rooms. Doctors would go. The worse a patient's wound smelled, right? That meant that they had to go as very quickly to attend to that wound, because any good doctor would say, oh, there's lots of foul airs in this one, right? Got to get to him quick as possible. No time to wash my hands between the last patient and this patient, right? No time to change my bloody gown. I don't want to do that. What I'm going to do is just wipe my hands on my chest and jump in there as quickly as possible, because I want to save this patient's life, because I can smell the foul airs. And then there was this crazy guy by the name of Pasteur, right? And he was like, you know what, guys? I think that infections may actually be caused by these little crazy things called microbes, right? And everyone thought he was a liar. Everyone's like, no way. And so we continue to do practices like when there's a patient who's extremely sick in the hospital, we bring flowers to their bedside, right? To get those foul airs. Right? This is a practice that we still engage in. But once this actually gained traction, and there was a surgeon by the name of Dr. Joseph Lister, and he decided he didn't think Pasteur was crazy. And he decided to do things like sterilizing his surgical equipment with carbolic acid and making his surgical residents wash their hands in between surgeries. And what do you think happened? Patients coming out of his surgery went from a almost 50% mortality rate to a 15% mortality rate, because he addressed the underlying cause, right? And when we understand the science, we can actually take the science and put it into practice in a broad way, right? That for me is akin to germ theory. So what does that look like when it comes to ACEs and toxic stress? Number one, it means raising the awareness. We need to be sounding the alarm on this public health crisis, right? And I think an important part of raising awareness is also packaging the message in a way that it can kind of replicate virally. Because as much as I love being out here talking to y'all, right? My husband and I, we got 4 kids. We got 4 boys, right? And in order to make sure that my own kids don't get toxic stress, right? Like, I need to be home to be that safe, stable, nurturing relationship for them. And I also need to know how to put my own oxygen mask on, right? So making sure that this work can be happening, right? While we are able to measure and balance, have some balance with this work is really critically important, because this is long work, y'all. And so we have to preserve our sustainability. We also have to engage strategic champions and partners, right? And then the next step, which is really where it feels like we are in the movement right now, is building networks that help us to reduce the obstacles to doing this work and supporting the practitioners in being able to do that. And so one of the things that we've done at the Center for Youth Wellness is to create something called the National Pediatric Practice Community on ACE Screening, which is a website that any primary care clinician can sign up for, right? And it helps to share tools around, like, how do you get your practice ready for ACE screening? What tools do you use to screen? What do you do when you identify ACEs? What diagnostic codes do you use? All of this is part of the National Pediatric Practice Community on ACE screening. And even more than offering solutions, it's this co-design network that gives an opportunity for people to share what their challenges are, right? To surface these obstacles so that we can work together as a community to solve them. And guess what, y'all? It's working! So, the 2 slides here The one in blue is the number of media articles on adverse childhood experiences and the health outcomes. And the two with purple and green are actually the number of research studies that have been published between the connection of childhood adversity and health outcomes, right? So we're not only raising awareness, but we are advancing the science and increasing the numbers of researchers who are interested in investing to find solutions. Because what we know, what the science shows us, is that safe, stable, and nurturing relationships improve outcomes. And when I'm talking about improve outcomes, I'm not talking about they make us feel better. I'm talking about they literally change brain structure and change the way our DNA is read and transcribed. I don't know how many of y'all are familiar with Michael Meany's work at McGill University, but chapter 6 in your book, right, is called Lick Your Pups. And what Meany did in his research study is he took these rat pups, and his researchers stressed them out. And then they gave them back to their moms, right? And some moms did lots of licking and grooming, lots of nurturant caregiving, the human equivalent of hugs and kisses, right? And some rat moms didn't. And the pups that got the high licking and grooming, they did better on cognitive tests. They had a more normally functioning stress response. And when they grew up and they had their own babies, they grew up to be high lickers themselves. And what these researchers at McGill University found was that that these changes were actually associated with changes in the way DNA was marked, changes in epigenetic regulation. But then guess what they did, right? I don't know if Michael Meany's been watching the Lifetime channel, right? But they literally switched these pups at birth. And when these pups were switched at birth, the pups that were reared by high-licking moms, right, who were genetically from moms who didn't do a lot of nurturant caregiving, but who were reared by high-licking moms, they performed better on cognitive tests. They had a more normally functioning stress response. They themselves became high lickers when they grew up. And they had the epigenetic changes that were associated with their rearing mother, not their genetic mother, right? Nurturant caregiving literally heals us all the way down to our DNA. Right? And that is really powerful. So when we think about how do we implement solutions, right? It starts with taking the science and putting it into practice, supporting safe, stable, and nurturing relationships and environments for kids, supporting environments in which kids can reduce their dose of adversity, normalize their stress response system, right? And get greater levels of buffering. Because we all can create change. If you are a pediatric clinician, join our National Pediatric Practice Community on ACEs. If you are a parent or a caregiver, learn about the signs of toxic stress or whether your child is at risk or what you can do. If you're a grandparent, learn about the signs. If you're a neighbor or a sister or an auntie or an uncle, right? Learning about what this looks like. Our center also developed a website called stresshealth.org, where we as grown-ups can go on and do our own ACE screen and learn about what solutions that we can do in terms of supporting kids. If you are an advocate, and I'm guessing that probably every single person in this room is an advocate, we have this powerful ability to join our voices with others to raise awareness and promote solutions that support all communities. And that means advocating for routine screening in primary care and evidence-based interventions, supporting best practices including home visiting, mental health, social work, and two-generation interventions, supporting the research, right? In investments in research that will advance detection and treatment, and working to enact ACEs-informed policies and practice, not just in healthcare, but in housing, in education, in child welfare, in mental health, in the justice system, in our workplaces, and in every segment of our society. And the last thing that I will say is that as we do this work, right, and as I mentioned, this is long work. And when we're talking about 2/3 of Americans who have experienced adverse childhood experiences, we're not talking about those folks over there. We're talking about us, right? And if there's one thing that we know is that we got to do what they tell you on the airplane, put your own oxygen mask on first, right? We have to practice self-care. Self-care is not selfish. That is what is going to allow us to be present, to be that buffer, right? To do this long work. And I believe that when we do, practice what we preach, when we do support systems that not only support children, right, but also support the adults and the caregivers that are in their environments, I believe that not only we can, but we will see a profound change in the way our society recognizes and responds to adverse childhood experiences and toxic stress. Thank you so much. I hope you'll join me in this work. Thank you. Thank you. Thank you. I'm happy to take some questions. Go ahead in the back. So the question is whether or not we utilize aromatherapy as part of our interventions. And the short answer is I definitely do personally. I do feel on a personal level like aromatherapy is a really powerful just thing for me. So all the data that I've been talking about, at our center, we hold it's a pretty tough standard of evidence. We look across, we look at, for example, interventions that have had randomized controlled trials. We look at interventions that have, meta-analyses and large-scale epidemiologic data. And for the interventions that we put out there as recommendations, they have to meet that standard of criteria. And I haven't seen I haven't seen studies on aromatherapy that have met that, randomized control trial, large-scale epidemiologic data. So that's the reason why we don't recommend it specifically. We do, however, in our center, we do use it as a promising intervention, and we look at some promising interventions that are based on the biology of adversity and what are the systems that are in play. So we need more research. That's my answer. Thank you. Go ahead. Yeah, the question is, what is the oldest age where we see that things don't really work? And the answer is 179. So, yeah. Yeah. So let me say that when it comes to early intervention, so specifically, a lot of the research has been on how early intervention, what are the tools that we have with early intervention? And one of the areas where there has been the greatest amount of research is on neuroplasticity. And there's two types of neuroplasticity. There's synaptic plasticity, which is the strength of the connection from one nerve cell to another. It's like changing your voice from a whisper to a shout. And then there's something called cellular plasticity, which is the number of nerve cells that are talking to each other, which is like the difference between one person shouting and a stadium shouting. And about 90% of cellular plasticity occurs by the 6th birthday, with the rest stretching out until about 25 years old. But synaptic plasticity is lifelong, right? So there's that happens throughout the lifetime. And what's really, so what we know is that when you do early intervention, you have the opportunity to take advantage of both types of neuroplasticity, right? So you just have more tools to kind of wire in these neurological changes when you provide supportive and enriched environments. When you start later, then you have, you need a higher dose of the intervention, right? The intervention often needs to be more intensive. It's often more expensive. And the challenge is that it's less likely to be, to have the same impact or effect size. But it's never too late to begin doing interventions to help regulate the stress response. The other thing that I think is really critical is that when we look at the biology, it gives us great insight as to additional windows. So a lot of folks look at this research around neuroplasticity and they say, oh, 90% by the 6th birthday, and so, after that, we're done. And one of the things that understanding the biology helps us to understand is that there are other things that also open up or expand additional windows of neuroplasticity. And one of those is hormones, right? That's why I say don't forget about the hormones. So pubertal hormones, puberty is a time of enhanced learning and neuroplasticity. And so pubertal hormones actually open up additional windows of plasticity. So that is a time where intention intervention can have, where we can leverage our biology to get an increased effect around puberty. And the other time is pregnancy and parenting, right? Pregnancy and parenting, again, our biology is wired such that when you're pregnant and when you have a child, it's a time of enhanced learning. And so when we implement these supportive interventions around pregnancy and parenting, we have an additional biological leg up for that to help to improve outcomes. Sure. Question here. Yes, you.
To add on to this question, so when you talk about doing the family work together, the 2-generational work, and you most often, when we're looking at parents, kids who have these parents, they often didn't get what they needed as well, right? So when that work's happening in the 2-generational work, are you looking at the adults' hormones? Is anybody helping them with that piece around addressing the plasticity for the adults?
Yeah.
And what other types of interventions are happening for them so that they can actually start showing up for their kids in ways they were never taught?
So the question is, when we're talking about kids who have childhood adversity, oftentimes their parents, they themselves did not get a lot of things that they needed when they were children, and whether or not we're looking at the adults' hormones or how do we support, how do we address this process in adults. And this is the piece that I feel is critically important, and that's something that we do at our center as well. In the deepest well, in your book that you have, one of the things that I talk about are 6 interventions that where we have the strongest evidence for addressing the changes the biological changes associated with toxic stress, which are the changes to the neurologic, hormone, and immune system. And and those 6 interventions include sleep, exercise, nutrition, mindfulness, mental health, and healthy relationships. So those are the 6 interventions. And one of the things that we recommend is kind of also speaking to the point before, like when we're dealing with kids and we have greater neuroplasticity and kids, we can affect their developmental trajectory. We may need a lower dose of intervention, but when we're dealing, especially with adults, one of the things that we recognize is that we may need to overlay those interventions, right? So we may recommend for adults, okay, we're working on that hour a day of exercise, and plus we may throw on top of that a mindfulness practice, and plus on top of that, mental health intervention, and helping folks to understand. And one of the things that I think is critical in framing to support caregivers is helping them understand, because of what you've experienced, your body may be making more stress hormones than the average person, and that can look and feel like being quick to anger or getting, feeling sick easily when you're overwhelmed, right? And one of the things that it helps caregivers be able to do is recognize, okay, when do I notice that this is happening, right? And when this is happening, what are the tools that I have to be able to address it? Once folks recognize, like, oh, snap, this is just my stress response system. It was designed to save my life. Is doing its job a little too well because of all the things that have happened to me. But it doesn't, like, when I get that overwhelming feeling, right, I recognize, like, I gotta do a little pulse check. I gotta look around and say, is this really a bear in the woods? Or is this my child reacting to something going on in our household? And that's a lot of the work that we do at the Center for Youth Wellness, is helping caregivers be able to recognize and understand when they themselves are having an overactive stress response, and what are the tools that they can use to be able to address that for themselves. And that ultimately, for most families, is what's going to make the biggest difference. Yeah. All right, let me find someone way in a corner over here. Yes. In the purple or burgundy.
Based on that, starting with the underlying issue, have you had any success working with obstetricians, hospitals that support to help parents be screened for their number of ACEs and preventatively put education programs in place at that point, as opposed to once the families come to the pediatric clinic?
Yeah. So the question was, have we had success in helping obstetricians incorporate this into their practice, and doing that screening there, or doing the screening in adults before the kids come into the pediatric practice? And that's been a really interesting process, I will say. So we're based in the San Francisco Bay Area. Kaiser Northern California actually did a pilot of ACE screening in their OB practice. And it was a really interesting experience. And this is actually why we created the National Pediatric Practice Community on ACE screening, is because if this were easy and there were no obstacles, like, we'd have done it already, right? And so where the innovation and where the real groundbreaking work is happening is around, like, trying things and seeing if they work, and when they don't work, or when we have challenges, or when we have obstacles, sharing that with other people so that we can bring the collective wisdom to be able to try things differently and learn from each other. What we learned, I just talked to the physician who did that work, and what she said was one of the biggest challenges that they have is that although ACEs are associated with changes with increased risk of adverse perinatal outcomes, that oftentimes the baby is kind of this abstraction. And folks, when we're talking about addressing ACEs and addressing our individual histories of adversity, in the OB setting, it can be what they encountered in their practice was that it was a little bit challenging for these prospective moms to kind of really get their hands around addressing these challenging histories because the baby isn't born yet, right? Like they hadn't what the doctor said to me was they didn't have the baby to serve as an object, right, for which like, oh my goodness, I'm going to do this. And what I found in pediatrics has been that oftentimes parents are willing to do for their children what they haven't been willing to do for themselves, right? And so we're still learning. We're still trying to figure out how do we do this better in OB. There's a practitioner in Oregon, R.J. Gillespie, who actually screens parents. And he's a pediatrician, but he screens parents at their 3-month well-child visit. And his screening protocol is part of the National Pediatric Practice Community as well. I think that's all we have time for in terms of questions. I want to thank you all so much for your kind attention, your fantastic questions. This has been a joy, and I'm really excited to hear how you guys move forward. So thank you.